My research focus is really very much aligned with my clinical practice. And for the last 20 plus years, I've really focused in the areas of advanced heart failure and all of the therapies that go along with that. So I've spent a lot of time working on not only pharmacologic therapies and electrical therapies to treat heart failure, but more frequently have focused on studies around cardiac transplantation and mechanical circulatory support. As a branch of that, one of the other approaches that people are talking more about is palliative care and how palliative care approaches fit into the overall treatment regimen of this very sick patient population, because despite the fact that transplantation and LVAD therapy is very exciting, there's a lot of interesting developments, especially in VAD therapy. It's really offered to a very small proportion of the larger group of patients that has advanced heart failure. So as a result of that, we designed and ran a clinical trial that was presented at the Heart Failure Society of America yesterday called PAL-HF, and it was a palliative care and heart failure trial. And PAL-HF was a single center study, a randomized controlled clinical trial that had two treatment arms. One treatment arm was guideline-directed medical therapy, and the second arm of the trial was guideline-directed medical therapy with a palliative care intervention inserted on top. And the question that we asked in PAL-HF was, does the addition of palliative care principles to a group of patients with advanced heart failure and a high predicted risk for either rehospitalization or death in the next 6 months, does it have a favorable effect on quality of life? And so we used two distinct quality of life tools. We looked at the Kansas City Cardiomyopathy Score, which was a score that really focuses on heart failure related quality of life. And then another tool we used was called the Facet PAL quality of life tool, which really focused on more palliative care related principles. And we were able to show in a study of 150 patients that the addition of palliative care on top of this of routine heart failure therapy actually improved both of those markers, and it was a positive trial. Yeah, I mean, well, there were a couple of things that I thought were very interesting about PAL. So first of all, we were able to enroll 150 patients in one center in 3 years, which was tremendous. I think it was a real tribute to our study team. But in addition to that, I think it really speaks to sort of the potential need and use of this kind of approach. We tried to put a little bit of science behind palliative care. You know, it's something that a lot of people are talking about, but it's still kind of in its infancy, especially as we begin to put it with new disease states. So there's a reasonable amount of palliative care research that's been done in oncology, but really, if you begin thinking about some of these other disease processes where there's a very high risk for mortality and a high symptom burden, it's very logical to begin applying palliative care principles, to that patient group. The third thing was that we focused in on this very sick group of patients, and we utilized a risk score that we developed from the ESCAPE trial, and we believed that we were going to find a patient cohort that had about a 50% mortality risk at 6 months. It turns out when we applied that risk score to this patient population, it didn't perform quite that well, but we still were able to identify a patient population that had about a 35% mortality risk at 6 months, so a very sick patient population.